Hey there, and welcome. So today we're going to put on our detective hats and dive into a medical mystery. It all starts with something that, let's be honest, a lot of us might just brush off, a single new spot on the skin. But you're about to see how this one tiny lesion triggers a pretty high-stakes investigation. It's a great reminder of just how critical it is to listen to what our bodies are telling us. So let's jump right in.
So, picture this. It starts with a pretty simple, everyday moment. We've got a 73-year-old man, and he notices a new spot while he's just checking his skin. And that one little observation, it's the starting gun for a really complex diagnostic journey. The big question is, what exactly are we looking at? Let's get a much closer look.
Okay, so this is the view the doctor gets, and honestly, it changes everything. What might just look like a simple red spot to you or me is, under a special magnifying tool called a dermoscope, way more revealing. You can see that red or, erythematous background with a bit of scaling, but the real giveaway, the crucial clue, are these tiny little dots. They're called glomerular vessels. Basically, they're malformed, stretched-out blood vessels, and for any clinician, that is a huge red flag. It's like a signpost pointing towards a potential neoplastic process. In other words, abnormal growth.
All right, time to open up the patient's file and get all the facts straight.
So here are the key details. Our patient is 73. He's got this new, red, scaly lesion on the shaft of his penis. It doesn't really hurt, but it does bleed sometimes. Now here's the kicker. The one detail that completely changes the game. He has a history of numerous other skin cancers. So for the doctors, this isn't just another spot. No way. It's like seeing a puff of smoke in a house that's already had several fires. You take it very, very seriously.
So, with all these facts in hand, the real diagnostic puzzle begins. What on earth could this be?
In this table, it just lays out the challenge perfectly. The list of potential culprits, what doctors call a differential diagnosis, it's pretty broad. It could be something infective, like warts, or maybe inflammatory, like psoriasis. But when you consider the patient's history and what the lesion looks like, the investigation zeroes in pretty fast on the most serious category, neoplastic. And that gives us three prime suspects: Bowen's disease, Bowenoid Papulosis, and Erythroplasia of Queyrat.
Okay, let's meet suspect number 1, Erythroplasia of Queyrat, or EQ. Now, this is a form of something called penile intraepithelial neoplasm, PeIN for short. All that means is there are precancerous changes happening in the skin cells. EQ usually looks like red, shiny patches, and it pops up on the mucosal or non-hairy parts of the penis, like the glands and foreskin.
Suspect number 2 is Bowen's disease of the penis. It's also a type of PeIN, but it's got a key difference. It shows up on the keratized or regular skin, like the shaft, which is exactly where our patient's lesion is. And instead of being shiny, these patches are usually red and scaly, and they can even look kind of warty.
And our final suspect, Bowenoid Papulosis. This one is really interesting because it's strongly linked to a specific cause, the Human Papilloma Virus, or HPV. These tend to show up as flatter, warty-looking lesions. Now, the main reason this one's a bit lower on the suspect list is the patient profile. It usually affects younger, sexually active men. So while it's probably less likely for our 73-year-old patient, you just can't rule it out yet.
Okay, so we have our list of suspects, but when you're dealing with a potential cancer, suspicion just isn't good enough. There's only one way to get a 100% definitive answer and find out what we're really up against.
And this right here, this quote, it really drives home just how urgent this is. When doctors even suspect erythroplasia of Queyrat or Bowen's disease, a biopsy isn't just a good idea. It's not a suggestion. It's an emergency. The absolute #1 priority is finding out if this precancer has already crossed that line and become a full-blown invasive cancer.
And so, a shaved biopsy is done. A tiny sample of the lesion is taken and sent right over to the lab. Under the microscope, a pathologist can see the true story. The size, the shape, the arrangement of the cells, all of it will definitively tell them who our culprit is and exactly how far it's gone.
After a careful examination of that biopsy sample, the pathology report comes back, and it has a conclusive verdict.
And the verdict is Bowenoid Papulosis. It's funny, this was the suspect we thought was least likely because of the patient's age. But hey, the microscope does not lie. The report confirmed there were full-thickness abnormal cell changes, but, and this is the most important part, there was no evidence of invasion into the deeper tissues. The danger was contained.
Thankfully, the treatment for this is pretty straightforward. It's a procedure called curettage and cautery. First, the lesion gets scraped away with a little tool called a curette. Then, the base is lightly cauterized,
or burned to stop any bleeding and zap any microscopic cells that might be left behind. And then they do the whole thing a second time, just to be sure, which gives it a really high cure rate.
So, our patient's case is solved, which is great news, but the story's not quite over. His diagnosis gives us the perfect chance to zoom out and really understand the bigger picture here, to see why telling these conditions apart isn't just some academic exercise. It's a critical, potentially life-altering distinction. Just look at this number, 10 to 33%. That's the estimated risk that Erythroplasia of Queyrat, one of our top initial suspects, remember, will progress to invasive cancer. At the high end, that's a 1 in 3 chance. That is a massive risk, and it's exactly why everyone was moving so fast.
And this is the absolute key takeaway right here. You've got two forms of precancer, right? But where they're headed, their futures are just wildly different. On one path, you have erythroplasia of Queyrat with that high risk of breaking through and becoming invasive. And on the other path, you have Bowenoid Papulosis with a very, very low risk of ever progressing, especially in someone with a healthy immune system. Making this distinction changes everything.
See, different risks require totally different strategies. A high-risk condition like EQ often means more aggressive treatment, sometimes even circumcision to just get rid of all the at-risk tissue. But for our patient's low-risk Bowenoid papulosis, the approach is much simpler, a lot like how you treat viral warts with things like cryosurgery, topical creams, or the simple curettage that he had. And since it's linked to HPV, the HPV vaccine can even be a part of long-term management.
So there you have it. Our medical mystery is solved, and it all started with just a single lesion. It led us on this diagnostic journey that really highlights the massive difference between what something looks like and what it actually is. Think about it. In this case, catching it early and getting that precise diagnosis was the difference between a simple in-office procedure and potentially life-altering surgery. It's such a powerful reminder that, when it comes to our own health, we're the first detective on the scene. That tiny little clue that you notice, it could be the one that cracks the entire case. Thanks for joining me.